So we've called this session Midwifery Matters at the NMC, and I have to thank my colleague Verena, who's still back on the stand, because she came up with this title way back, because it was actually talking about the work that we do within the NMC. And if you read it, it means that I'm going to talk about midwifery matters, but actually what it's really saying is that midwifery matters in the NMC. And I think that's really, really important, which really depicts the work that we do. So, a little bit of an NMC update. So this is a bit of a smorgasbord, lots of different things that we've picked out, just to give you a flavour about what's happening with your regulator. So we currently have an acting chief executive and registrar. Her name is Helen Herneyman. She was already within the organisation as one of the executive directors. And then we're actively recruiting at the moment for an interim CEO and then subsequently for a permanent CEO, which is launched this month. And that was because we lost Andrea Sutcliffe, who'd been with us, I think, 5 years plus, sadly, to ill health. We've had quite a difficult summer. I've already spoken to a few of you. In July 24, we had a People and Culture report that had been done by Nazir Afzal and the Rise Associates. And they were a company that actually looked into the London Fire Brigade when they were also experiencing issues. And this came about that the NMC asked them to look into issues that a whistleblower had raised within the organisation and externally. And I've just really, there isn't really much to say in terms of progress because it's still early days. I have to say, if you read the report, the experience within the organisation of different employees is very, very different. For Verena and I, we say it's been very positive. We continue the work that we do. For others, it's been very challenging. But the organisation has accepted the recommendations in full, apologising, and they have got a change programme in full because they know that registrants need to have confidence in their regulator. It's not going to be a quick job. It will have to be work that's done over a period of time. And of course, the midwifery team, we're committed to supporting this work. And I remember the very week that the report came out, and I was in Hull talking to student midwives and midwives. And I said to them, you know, I'd had to reflect about whether this was an organisation I wanted to work with. But then I thought, well, it's easy, isn't it, to walk away? And maybe we've got to really work hard to be part of the solution. And one of the things that I've done over the summer is become an Empowered to Speak Up ambassador for people who in the organisation want to talk through their concerns to see how we can work that through and what they need to do next. So this is the midwifery team. It's been Verena and I for quite some time. And then in March, Tracy McCormack joined us as our assistant director. And she was a director of midwifery at King's College in London. And between us, I think we're quite a formidable team. We're definitely getting things done. I think, you know, it's quite interesting how we're just continuing work to progress midwifery within the NMC and beyond. And between us, you can see we've got a huge, we cover all bases. We've all obviously been in hospital and community experience, including home births, free births, and we've got management, leadership, education, policy experience. And I think that's really important that you have confidence in that team. There are other midwives in the organisation. So, for example, we've got 4 midwives working on advanced practice, and I'll come back to advanced practice in a minute. And obviously, we've got midwives working in the clinical advisor team, and I think those roles will be strengthened. And what Tracy's beginning to do is try and embrace every midwife in the organisation, so we come together to make sure we share our work and intelligence. We've had a plan for a long time, but we've actually formalised it now because I think we need to shout a little bit more, particularly at council, as to what we're doing as a midwifery team. So we've got this work plan, and it's included our strategy and insight colleagues, and we presented it to Council in May 2024. And what this is going to be is really a live document, really documenting comprehensively everything we do for midwifery within the organisation. And that's important to know, because actually where we need support to do other pieces of work, whether it be resources, funding or whatever, if we can actually articulate really clearly what we're doing, we're much more likely to get traction. Because a lot of the nursing colleagues have like sort of projects, if you like, within the organisation. Midwifery tends to be part of that. So we needed to really raise the profile of what we're doing. And we've got 7 current work streams. And some of this will be absolutely for what we are doing within the organisation, but some is actually working collaboratively with colleagues, whether it be the chief midwifery officers, whether it be other education colleagues, the universities, etc. So midwifery workforce is of course part of it, as well as the unregulated people work. Where it talks about midwifery team governance, it's how we can raise the profile of midwifery with council and the executive board, so they know that midwifery is that separate profession within and we have our own particular needs, as well as when we can be aligned with our nursing colleagues. We're obviously inputting into education and quality assurance as that develops, the culture, safety and leadership reviews that have been going on, trying to work more multidisciplinarily, particularly people like CQC, and we continue to work with the RCM and the RCN, as well as continuing to embed the standards.
Can I ask a question?
Yes, of course. Where are?
Yeah.
Yeah.
The unregulated people, what do you mean by that? Do that support workers?
No. Yeah. Just hold that thought, because I'm going to cut a whole section on it. Yeah. So, as you know, we had new standards in 2019. Gosh, that's 5 years ago. But we still need to work on embedding them, because these standards are not just for students undertaking programmes. They're for all of us practising as midwives. So that particularly when you revalidate, you'll revalidate on the code and the standards of proficiency for midwives. But what we did some time back, post Ockenden and post Kirkup, is we mapped the standards to say, hey, the recommendations are this is all what midwives should be doing. You know, they're there. But we actually extracted those proficiencies out, if you like, to really make that. So we did that, and we're committed to do it when Nottingham reports as well. But we decided to do another document, which was exactly the same stuff that we put out, but we've actually sent it out now to the DOMs and the HOMs. And we sent that out in July. And what we've asked them to do is map what their midwives are doing to assure themselves that they are upholding the standards, and talk to their boards about what it is where they may be lacking. So it could be that there are particularly standards that are not being done so well, or perhaps not at all, and particularly thinking about students as well, and they need support of their board. And we'll need to review. It's been landed very well. Being that we published it in July, we possibly haven't got feedback yet, because boards probably haven't sat over the summer. But we intend to evaluate that to see what else we need to do. Now, the other thing we made a change to the standards for pre-registration midwifery programmes recently. With best intention, following the work we did post leaving the EU, we changed some of the language to be much more woman-centred, and we did it with really good intentions. And we changed the word conducting births for students to facilitate. But what we realise is that we've inadvertently perhaps diluted that standard, and it doesn't map the standards of proficiency. Now, I don't particularly like the word conduct, and a lot of our colleagues don't, and Birthrights have challenged us on it. But I think it really says what a midwife does. Whereas if you go on to say, for example, Doula UK, they use that word facilitate. So it was really important. So we engaged with the stakeholders, sought legal advice, and we changed it on council approval in July. It doesn't make any difference in terms of what your students are doing. A lot of this work is to show the public what the protected function of the midwife is. In terms of workforce, we continue to work on adoption and any opportunities we have to talk about the standards, we do. We'll obviously keep our standards under review as evidence is emerging. You know, we've got a CQC report coming out tomorrow. I'm not sure when it's going to be in the public domain, but it's definitely coming as an embargo copy to us. But we need to look at those recommendations to map them. I've got every confidence that what they're saying is in our standards, but we must always keep that under review. And similarly, the test of competence, which our international colleagues are doing to rejoin the register, or midwives who are returning to practice, we need to make sure that is aligned as well. And of course, we must continue to work in the space where things like the WHO policy around ethical recruitment is the new EU directive that is coming, as well as maternity services review. So that's very much our external sort of work. We've also done some work around internationally educated midwives. I'm sure many of you in the audience perhaps are working with internationally educated midwives, because we want to understand their experiences and we want to strengthen, you know, in terms of what happens when they've actually joined our register. And there's been a number of sort of projects that's been ongoing within our teams, including the test of competence to strengthen the guidance, as well as other policy work and stakeholder engagement. And the big piece of work that our employer link service has done is actually doing some Welcome to UK workshops with the internationally educated midwives. And what they found has not been good to hear. Some of them are having very, very poor experiences. So there's definitely more work that we need to do within that workforce. Here we go. This is the one, unregulated people. So Verena and I had been getting a number of inquiries from various people, mainly heads of midwifery, telling us about people that were working in their sector, and they were concerned that they may be undertaking things that only a midwife should do under the protected function. And we kept sort of saying, well, really, this isn't anything to do with us, because actually we regulate nurses, midwives and nursing associates. We don't regulate nursing doulas. We don't, you know, we've got very strict criteria in terms of remaining on the register, etc. But as time went on, we realised it was gathering pace and we needed to potentially do something. So we decided that we would set up some stakeholder meetings that we would chair in terms of trying to discuss the way forward. Now, when we talk about unregulated people, it's a very clunky sort of phrase, but it was the best we could come up with to describe who we're talking about. And I don't want you to go away to think that doulas don't have a place, because doulas are doing some amazing work, giving fantastic psychological, social support to many women. But what we're concerned about is when doulas are stepping into doing things that are actually the role of the midwife. And we knew that this was happening, and it's quite difficult to really get the evidence. It's all sort of a little bit kept under wraps, and women don't tend to want to come forward. But we were hearing examples where community midwives would arrive at a house following a birth that had been taken place. You could argue, is that a free birth, is it a BBA, but whatever it was, and then finding a room full of equipment, entonox, drugs, and an episiotomy having been performed. And then anything in between, you know. So it was a very worrying thing that we thought about, we were hearing. So we held this stakeholder meeting probably way back, and then this was about our third meeting that we had in June. And a lot of that time was really trying to move on, because what people were saying, well, the NMC must tell midwives what to do, particularly when women are free birthing and they won't let them in the house. And what we had to try and move people along is to say, well, look, this is what we can do, but this is what the sector needs to do. So we've sort of got there. And when I talk about those stakeholders, I'm talking about directors of midwifery, consultant midwives. We've got the police now around the table. We've got Doula UK, we've got birthrights, we've got service users. So it's a really good mixture, and it's also representative of the 4 countries, because the main problem has been in the southeast, but actually it has moved up the country. And Wales certainly has had a number of these issues. And the reason that Verena and I felt we have to do something about this is that we feared that mothers and women and babies were at risk. And we know from certain reports that babies have been involved, and some babies have died when a doula has been present, but a midwife has not been present. And we now have a maternal death in Ireland. So we sort of anticipated this was going to happen, which is, an absolute tragedy. So what we decided to do is we've been put into 3 task and finish groups to work collaboratively to co-produce UK-wide principles. Now, the NMC can't produce something to say the trust must do this and must do that. That we haven't got the authority to do that. But what we can do and the principles are very similar to our preceptorship principles, where it's talking about good practice. So what it would really expect is that trust and health boards will be able to take this forward. So I'll give you a tangible example, and this is not set in stone, so don't quote me. But we've heard that we've got policies that mean that the midwives can't go to give care. The trust absolutely refuses, and the woman knows that no midwife is going to go because the woman is free birthing or birthing out of guidance, and they've got to call an ambulance if they need. But what we have found is that those policies have not been developed reflecting the code or the standards of proficiency. So it's putting midwives in a very... Because if you actually did a policy looking at the code and the standards, you'd end up with a very different policy. And then it's things like ensuring you have the right training, the right communication. So all of these things. So at the moment, we've been looking at it from the perspective of the midwife, the woman, and then the service. But ultimately, it's all got to come together, and then we decide how it's going to be presented. So we're working at pace on that. We've got a follow-up meeting in October, and then we hope to get those principles out before Christmas, or at least early in the new year. And I think midwives are crying out for that. At the same time, we've been strengthening our processes so that if somebody finds they're in that position, that they think someone's acting inappropriately, that they've got a route into us and we can take that forward. And some of our regulatory powers would be to work with the police, who could then forward to prosecution, etc., and fining. And in terms of your question, this unregulated people captures anybody who's not on the register. So it could be an independent midwife who doesn't have insurance and then is caring for somebody in labour and birth. Again, this is very hearsay. I'm not saying this is happening, but they're sort of moving between being an independent midwife, antenatal, postnatally, and then something else in the birth, and that's a challenge. Could be somebody who's been on our register and come off the register for a whole range of reasons. It could be a doula who's never been on the register and had only had doula training, and sort of anything in between, really. But it's trying to capture that this person is not on the register, so they're not regulated.
Would there be a move to regulating doulas in some way?
Now, it's very interesting, that question, because we asked Doula UK, and they don't want to be regulated. Because the ones who are part of Doula UK absolutely understand their role.
If midwives want to be regulated, I mean, it's interesting. We were in our consultant midwife up in Birmingham and have been involved with lots of women with issues with birth outside of guidance and lots of fantastic doulas, but also that relationship between the doula and the mother is often much stronger than
Yeah.
so they're in a very influential position.
Yeah.
So I don't know, I feel like it's something that we're talking about quite a lot as consultant midwives. So I'm just, midwives didn't used to be regulated, did they, before the 1902?
Well, yeah, and if you think about historically, you had people that had no training, no education, potential harm to women, and it was very much to, it's talking about the safety, isn't it, of women and babies by the education that you have now and how you retain those skills.
Is that not what we're talking about with doulas? That they don't have that education, that training, but they are in, and I don't want to kind of I'm making huge sweeping statements about a huge group of people, but and I don't mean to do that, but there's something about how do we know how much training, how much knowledge, and what boundaries they're working within.
Well, that's the challenge, because obviously the women employ them, and we need to do some work around women understanding the difference between a midwife and a doula, because some doulas are absolutely essential to some women in terms of that psychological, social support they offer. And we're not worried about them because they're very clear about how they would work alongside midwives. But it's the people who are actually now going into that protected function of the midwife, which is obviously a statutory, which is law, that nobody other than a midwife, a doctor, or somebody in training to be a midwife or a doctor can undertake that care. It's very old-fashioned language, and we're going to continue to work under regulatory reform, which is coming, to see whether we can improve that, because it's still talking about attending somebody in childbirth. And we've actually done some work about what we mean by childbirth. And what we mean by childbirth is the point that the woman's in labour, through the birth, and that early postpartum period. But the language doesn't help, and we need to think about that. But it's absolutely not to vilify doulas. It's to stop the ones that are doing things that they shouldn't be doing, which could be at the detriment. And I think these high-profile, these cases that are going to come through, it's going to be really interesting to see what the coroners say. Yeah. So what we've done internally, because this has been important for us to get our house in order, is we've revised a standing operating procedure as to what we do when there is a potential breach around Article 45, which is the protection of title, because as you know, nobody can call themselves a midwife in this country unless they're registered with us, or Article 45, which is the protected function. Very much we've worked collaboratively to develop that SOP. We've strengthened those definitions within Article 45. And I think the most exciting development is we've at last got this more collaborative working with the National Police Chiefs Council. Because the other problem is, what do you do if you find that somebody is acting illegally and the police don't understand our legislation? So we have to work collaboratively with these people, so that when a concern is raised by a Dom with us, that they also take it seriously through the police. Advanced practice. I'm not going. These slides will be circulated, won't they, Sue? So I won't go in them in detail because I'm conscious of time. But I think it's just to know that we are working on advanced practice. Midwifery is in this space, and this has come all around the safety issues in terms of people, particularly service users, not understanding what an advanced practitioner is like, not actually looking at those advanced skills within revalidation, etc. So we've got the 4-country approach working on this, and midwife is in that space. And this isn't about the roles midwife do, this is more around scope of practice. And importantly, the RCM, if you haven't seen it, do look at that position statement. We are in early work with this, but we are looking towards developing programme standards of how you become an advanced practitioner in midwifery, and also proficiencies. And we're very clear, as is the RCM position, that this is about advancing the midwifery role, not undertaking sort of doctors' roles. So it's very clear. So it's early days with that. So do get involved with that, because this is really important for midwifery. Our council has approved that we will do this. We've got to continue to get this shared position, and we've got to have to think about this work on revalidation and the code as we go forward into the coming years, because it's not a piece of work that can be looked at in isolation. I'm going to just whiz through that because you can read that through, because I'll just snatch the last 2 minutes for any questions. So, yeah.
Do you also kind of within that framework look at like midwives kind of turning to obstetricians where maybe they don't know that they don't need to do that? Like, for example, if you have like a woman that, or like a birthing person that like declines a treatment, and your policy says that you need to explain the risks and benefits, but then you don't do that, you go and get an obstetrician to do that for you. Like, I've been in a situation where that's happened like more than once. Are you kind of looking at that as well? Like, because I see what you mean about like midwives understanding their scope of role and not doing things obstetricians do, like absolutely. But also I sometimes see it happen the other way, where they don't realise like where something is still physiology, where this is still something within your scope of practice, like you don't need to rely on an obstetrician, you're a midwife, like this is your expertise. Like I feel midwives have a general like lack of confidence.
I think it's about using those standards of proficiency, you know, which are excellent in terms of how they explain what the midwife's role is. There's a whole section at the front and really detailed proficiencies. I think there then is a bit of a juxtaposition between what your policies or guidelines say within your trust. Because if they're at odds with the proficiencies, like I gave you the example with maybe the free birth, you know, the two should align, shouldn't they really? Yes. And this is where your consultant midwives are absolutely pivotal in this, to make sure you do get that alignment so that it's very clear understanding. I mean, we're very clear that, of course, we work multi-professionally. That's really important, particularly for women with additional needs or complications. But it's actually that understanding of that role, isn't it? And having those right people in place to really explain that. It always smiles to me when, you know, I do a lot of expert witness work, when you actually read that a shoulder dystocia is diagnosed and then the consultant or the registrar starts coming in and starting to do the manoeuvres, whereas actually the midwife is very, very proficient, or perhaps more so, you know, in terms of that. But I think there's definitely thinking about that position of those standards within what's happening locally.
Thank you.
Yeah.
Hiya, I'm an independent midwife. I very often get contact from families who are free birthing. A lot of the time they just want help with birth notifications.
Oh, right, yeah.
Mostly because they've got the fear of God in them that they will be referred to social services. Yeah. Because they've been told that it's illegal to birth on your own, obviously wrongly. A lot of the time it's just so that they've had a professional to do the legal bit. How will your changes, your definitions of what is intrapartum care affect that? Because obviously I need intrapartum insurance.
Of course you do, yeah.
To attend a birth.
Yeah.
If I'm not attending the birth, but I am attending in the immediate postnatal period, when does that start? Can I attend a immediate postnatal without intrapartum insurance to notify the birth?
That's an excellent, and I think maybe we need to have a conversation at the stand about this. There is definitely a working group looking at that whole issue about notification of birth to try and get it absolutely clear, because there's definitely bodies out there who are not actually undertaking the role when they should undertake. I think when we defined the early postnatal period, we were really trying to talk about that it wouldn't be the placenta and membranes that would be delivered by somebody who was not a midwife, and there'd be control of hemorrhage. So there will be a point, you know, within 2-3 hours where absolutely you but I think you are in a really challenging position as an independent midwife, because when a woman has been turned away or not been able to navigate what she wants, and she's got maybe a negative relationship, she comes to you, and then you're in a position when you're perhaps caring for women who it's not best ideal for you to, you know, if you had a choice, but she's absolutely almost at the last sort of port of call, really. But I think it's more, if you're not having insurance, it's more about doing clinical care, isn't it? That's the issue. And going to a woman immediately postnatally, if you're not actually doing any physical care, but you're just notifying that, yes, you've met this woman before and you're notifying, but that's a sort of a totally different issue to if you're going to do other things.
They will often want a postnatal check. They'll want a perineal check to see whether they need sutures.
Yeah.
And
you could argue that's not what you would be doing.
Is that intrapartum or is that postnatal?
Yes.
NIPEs, is that intrapartum or postnatal?
A NIPE, I would say, would be postpartum, but the first initial check of the baby would be more part of that role.
It all gets very, very grey. My concern is that, you know, as an independent practitioner, I am available for that. They have accessed some midwifery care. It's safer than not accessing at all. But then to add in, you know, you've got the threat of their doula or their birth keeper then being reported to the police, as well as their threat and their fear of being reported to social services erroneously because there's actually no need. It's going to send people even further underground.
Yeah, and I think this is the problem with this whole thing that we're trying to look at. I mean, we're coming from a place of trying to promote safety for women and babies, but also for them to have the birth experience they want. But I think since we've had people sort of coming into that space, there's been this blurring of roles, as you've sort of described. And of course, it's working out whether this is doing something in terms of more of a Good Samaritan because it's been a genuine BBA, or whether it's and that again, the data on this is just not, you know, they're all going down as BBAs, so we don't even know where women actually are free birthing, you know. So it's a very complicated space, and I can absolutely hear why it's complicated.
But then,
for
as
yourself.
an independent midwife, I have no idea where that is leaving me and my practice, and who I can attend and who I can't. You know, if I have a full client, it's arranged. You know, I have intrapartum insurance for each client. Yeah. If somebody contacts me during pregnancy and says, I'm free birthing, can you come and check me and my baby and do the birth notification? I have no idea where that leaves me professionally.
Have you got time to come to the stand so we can really unpick this? Yeah.
That would be really, really useful, because I cannot get a clear answer from anybody.
And I think maybe, I don't know if you're part of IMA, but it might be that we need to engage with that group and you know, because when we get these guideline principles, we have engaged with you before with the proficiencies, it might be helpful to engage specifically for some of these things that you're raising. Yeah. Okay. Thank you so much. So we're here for the rest of the afternoon.